Hello, I'm presenting the case study 6, hypovolemic shock. The disorder is acute blood loss anemia. My name is Paulson Elekuru. Uh, Patient case introduction. The chief complaint, patient reported pounding in my chest after sustaining multiple stab wounds to the chest and abdomen. The history of present illness, HPI. Miss Casey is a 22-year-old woman, a college co-head, who after 35 minutes of enduring chest and abdomen stab wounds by unknown assailant or assaulter was presented hurriedly to the emergency room after a witness called 911. EMS arrived at the location of scene. They found her lying with significant amount of blood on her clothes and a nearby pavement and was in a severe acute distress. Was then they then obtained on the scene a vital sign, which heart rate was 128, baseline 80. The blood pressure was via Doppler ultrasound 80 over 55. Her baseline is 115 over 80. The respiration rate was 37 and it was labeled. Immediately following physical examination, Casey was started on intravenous lactated ringer solution at a rate of 150 milliliter per hour. A vital sign was obtained on the way to the hospital, which were again which uh, were heart rate 138, blood pressure now 75 over 50. The respiration rate increased to 38 with confusion. The intravenous fluid was double after she was diagnosed with hypovolemic shock at the hospital. Blood samples were sent for both typing and cross-matching and chemical and hematologic analysis. She was started on 3 liter per minute oxygen via nasal cannula and with repeated arterial blood gases laboratory order. At the emergency room, the physicians decided against starting a central venous line, but instead they inserted an indwelling Foley catheter with a return of 180 milliliters amber-colored urine. The urinary output in another 1 hour was 14 ml, but her condition improved over another 1 hour after the full resuscitation with 1 liter lactated ringer solution and 2 unit packed red blood cells. Ms. Z was admitted to the ICU for recovery, but that was after a successful surgical repair of lacerations that she sustained to the right lung, liver, and pancreas, and she received an extra 6 units of B plus blood type in the operating room. Description and epidemiology of hypovolemic shock. Hypovolemic shock is a state of decreased perfusion and oxygenation due to decline in intravascular volume related to loss of blood or extracellular fluid. Common causes of hypovolemic shock include hemorrhage, excessive emesis, diarrhea, burns, polyuria, and pore spacing, which is excessive fluid shunting from the intravascular space into the interstitial space. The prevalence of hypovolemic shock was found to be 3% among cardiac intensive care unit admissions, while the incidence of hypovolemic shock from non-hemorrhagic cause is the most common. In fact, 2.2% of huge or enormous transfusions of blood at level 1 trauma center were due to traumatic injury, with an excess of 75% of blood product used. Older adults are more likely to have hypovolemic shock due to fluid loss, which is related to decreased physiology reserves as a result of aging. Pathophysiology hypovolemic shock at the cellular level. The hallmark of the pre-shock stage is the compensatory mechanism, which is spearheaded by increased sympathetic tone, leading to elevated heart rate, increased cardiac contractility, a pronounced or widened peripheral vasoconstriction. The aftermath of the expanded sympathetic response is the initial changes in vital sign related to 10% loss of fluid volume, as evidenced by elevated diastolic blood pressure with decreased pulse pressure, with overall result of mildly elevated blood pressure. The continuing deteriorating volume status usher in a shock state with a decrease in systolic blood pressure at this uh, at this time, then tachycardia and oliguria, precisely as the depletion approaches 25 to 30% of the effective blood volume. Consequently, there's a mismatch between oxygen demand and delivery to vital organs like the heart and the brain. Hence, the body switching from aerobic to anaerobic metabolism by the body cells with the ensuing or the resultant lactic acidosis. The increasing sympathetic response results in the shunting of blood to the heart and the brain from other body organs and systems. Like I said earlier, this shunting broadens tissue ischemia and exacerbate lactic acidosis. In the absence of prone intervention, or immediate intervention, hemodynamic compromise, refractory acidosis, and diminished cardiac output will result will be the order of the day and consequently leading to multiple organ dysfunction syndrome, MOD, and eventual death uh, of the individual. Clinical manifestation, pertinent subjective data. The chief complaint was saying that the patient was complaining of abdomen and chest pain because she sustained a stab to the chest, multiple stab to the chest. History of present illness as detailed above. The past history, family history, social history, they have been postponed because of patient condition. Medical medications, medication also postponed. Allergies, no known drug allergy, also maybe as a result of patient condition, pertinent objective data. General appearance, she appeared very anxious with continual complaints of severe chest and abdominal pain. Chief complaint as detailed above. History of present illness has been already detailed. Vital signs, the current one at the ICU as she's recovering, the heart rate is 104, the blood pressure is 106 over 70, and the respiration rate is 21. Physical examination, the review of systems, the neuro is awake, her level of consciousness, she's awake, slightly confused with continued complaint of pain. Uh, the lower extremity and upper extremity assessment is postponed. Neck lymph node uh, postponed. Uh, the HENT is pupils are equal. They reactive to light. Round are reactive to light and accommodation. Respiratory test there are multiple stab wound which has been repaired to the right. Uh, the lungs or respiration is tachypneic. Uh, Our respiration is currently 21. She's short of breath with conversation, diminished breath sounds. The right lung, which at which is sustained a stab, uh, which is also a sign of lung collapse. This bacillar atectasis. Cardiovascular, she has a pale skin and nail belt but no cyanosis. Skin toggle poor, capillary review approximately 7 to 8 seconds, peripheral pulses absent except uh, steady brachial pulse. Pedal pulses was absent, and radial pulses weak, carotid pulses is palpable. The GIGU, the urinary output currently is 29 milliliter per hour. Musculoskeletal, as skin is cool and clammy. Diagnostic and laboratory blood stain results, they are shown on the screen. Uh, the first one, which is the initial one after she was brought from the crime scene. The diagnostic and lab result too. That's after she was resuscitated with 1 liter lactate ringer and 2 units of packed red blood cell. They are shown. And also the repeat arterial blood gases when she was administered 3 liters per minute of oxygen by nasal cannula, and is as shown on the screen also. The role of advanced practice nurse underpinned by the Christian worldview. The APRN plays a critical role in ensuring proper management of hypovolemic shock as follows. Number one, they help in identifying the type of hypovolemic shock, that is, whether it's hemorrhagic versus non-hemorrhagic. Things may be difficult to distinguish as this determines the type of intervention or treatment. Like the patient, in this case, 36, suffer hemorrhagic because of stab wound. Number two, the parent assists in prompt bleeding source control, identify the source of the bleeding and the control, and they make effort towards goal directed of volume resuscitation to restore hemodynamic stability. The APRN guide in preventing complications, including circulatory overload, abdominal compartment syndrome, transfusion related adverse reactions, as well as complications from surgical and radiology interventions. Number four, the APRN monitors electrolyte and acid-base uh, balances or imbalances or status and evaluate patient response to fluid resuscitation. Number five, the APRN coordinates the interprofessional team for rapid assessment and life-saving intervention or interventions for best possible patient outcome. Uh, the questions for the case study says, number one, with respect to the patient's clinical manifestations, what quantity of the patient's total blood volume has been lost? That's approximately. Number two, is administration of sodium bicarbonate essential for the patient at this point or currently? Number three, describe the pathophysiology of the abnormal blood urea nitrogen, BUN, and creatinine, or CR. The next slide is just the references, and thank you.